Good evening, Hemant sir.
Very good evening. How are you? All well?
Yes, I'm good, sir. How are you, sir?
I'm very good. So we have another 5 minutes.
Yes, sir. Rakesh sir is joining, sir. Rakesh sir is joining. We're just waiting for him.
Good evening, Dr. Prakash. Good evening, Dr. Chaturvedi.
Good evening. Good evening, everyone.
Thank you very much for being a part of this activity. We look forward.
Thank you. Thank you, Dr. Malhotra. It's very nice of you to organize meetings like this. Nice to meet people, even though it is virtual at the time.
Good evening, Rakesh sir.
Good evening, everybody. Good evening, Hemant sir.
Very good evening, Dr. Reddy. How are you?
I'm fine, sir. I'm fine. Good to see you, sir. We'll start dot at 7, sir.
Yes, sir. We start at 7.
Can we try the slide share for a minute?
Yes, sir. Team, can you just stop sharing the slides? Sir wants to test his slides.
So am I okay to try now?
Yes. Just give me a minute. Team, can you just stop sharing the slides? Stop it. Sir wants to try his slides. Yes. Sir, you can try now.
Okay, is my slide visible?
Yes, sir.
And the full screen is also there?
Yes, sir.
Sir, okay. I think there is some problem. Hi, sir. Ullas here.
Yeah, hi, Ullas. Good evening.
So there's some problem with the slide. It says Amitabh Bachchan.
तू नहीं मानेगा ना?
मैं कहाँ मानूंगा सर?
हाँ.
मैं मान जाऊंगा तो मैं नहीं रहूंगा ना सर.
Correct.
Hi, Ullas. Ullas, how are you?
Good, sir. How are you? More importantly.
Okay, getting better. Yeah.
You're looking very good, sir.
Thank you.
Okay. Rakesh, you are starting, no? I'm not starting.
Yes, sir.
Okay, you are starting. Fantastic. But I must say, I'm pleasantly surprised to see the number of people coming and joining here. I thought some only 5-10 people will join, but that's fantastic actually.
Yeah, I got on time.
So I think, Ullas, this is entirely the success of our chest colleagues.
Yeah.
If we had done a pure oncology meeting, then the participation would have been very lukewarm.
Yeah.
So we thank all our chest colleagues and our pulmonary medicine experts and our interventional radiologists. All of you have contributed big time to the success of this, and I hope it continues in the subsequent programs also.
But I mean, the only hope and pray is that the medical oncologist should also come and join.
Yeah.
I mean, so we have audience on Zoom as well and even on the website.
Okay, so I think I have distributed it to my residents also, and everybody seems to be very keen in joining. So I'm sure we are going to have a good crowd. Kumar has joined?
No, sir, he'll be joining. I have given him a call. I gave him a call. So, shall we start, sir?
Sure.
Dr. Prashant, you there? Hello, Dr. Prashant. Am I audible to you? Hello. Ullas sir, am I audible?
Yeah, you're audible.
Okay. Prashant sir is there, but is not responding.
Yeah. Hello.
Hello, Prashant sir. Yes. Good evening, sir. Yes. So, are we good to go, sir?
Yeah, I think we should. Dr. Hemant, sir, shall we start?
Yeah, I'm ready.
Rakesh, sir?
Yeah, fantastic. Let's go ahead.
Yep.
Yes.
So we haven't done a minute-to-minute practice. So Ullas, you tell me when do I come in, okay?
So I think, sir, Dr. Rakesh will get the ball rolling, and the in between the MC thing will be done by the river out people only. Okay. So after Rakesh finishes, they will invite the chairperson. The chairperson will invite you. Just in case the chairperson are not able to join for any reason, then maybe the river out people can know all the speaker is.
Yes. We have Prashant sir.
Ullas, is it possible to display or share the slide of the program so that it's clear once again as to which particular session who's chairing?
We will do that, sir. We will do that. So you are chairing the Abhishek Bansal session from 7:15 to 7:30. I can just tell you that, sir. But we will do that. So the chairperson for the first session are Dr. Prashant and Dr. Abdul Khadir.
Dr. Abdul is not going to join.
Is not, sir. The chairperson for the second session for Dr. Abhishek Bansal is Dr. Chaturvedi and Dr. Roshan Pant. The chairperson for the third session for Dr. Rajiv Gola, Dr. P.S. Shahjahan and Dr. Jaiprakash.
We are here, sir.
And for the panel discussion, the stupid moderator over there is me. And the chairpersons are Dr. Rajesh Savarkar and Dr. D. Behra.
Yes, I'm there.
Okay, I think we're good to go. Let it be started with Dr. Rakesh.
Yeah.
Okay, so can I just introduce Dr. Rakesh?
Yeah, please go ahead.
Okay, so good evening all. On behalf of Academy of Lung Cancer, I welcome you all for the first meeting of the management of pleural effusion. I would like to invite Dr. Rakesh Reddy sir to give us the opening address.
Yeah, thank you. So it gives me great pleasure for this unique program, which we are doing under the banner name of Academy of Lung Cancer. This is a very unique platform that is envisaged by Dr. Kumar Prabhash, and a lot of groups have come on board. So it's a unique academic platform wherein medical oncologists, chest physicians, radiation oncologists, all the groups of groups managing lung cancer, the chest physicians, intervention radiologists, they all come under one banner to discuss these less often discussed topics, which they go into fringe part while creating any any academic program for lung cancer. So the idea is to bring them into forefront, these clinical problems. And for this particular meeting, we have the program directors as Dr. Hemant Malhotra sir, Director of Oncology Services at Sri Ram Cancer and Super Specialty Center, and Dr. Ullas Batra, Senior Consultant and Chief of Thoracic Medical Oncology at Rajiv Gandhi Cancer Institute and Research Center, Delhi, as the program directors. And without much ado, I would like to start the program by for the first session to be chaired by Dr. Prashant Chajay. And the first topic will be introduced, the speaker will be introduced by him. Over to Dr. Prashant.
Hello, Dr. Prashant.
Yeah. So, yeah, audible?
Yes.
Yeah. So thanks for this, this invitation and, on this forum here. And I think the first, I would like to invite the first speaker for this session, that is Dr. Hemant Malhotra, who's Director of Oncology Services at Sri Ram Cancer and Super Specialty Center and Professor and Head Department of Medical Oncology at the MGM College Hospital, Jaipur. And he's going to be speaking on approach to a patient with pleural effusion, the diagnostic perspective. Thank you, Dr. Malhotra.
Thank you, Dr. Prashant. If I may be permitted to share my screen. Is the screen visible?
Yes, sir.
Okay, wonderful. Thank you very much. So today I'm going to be talking to all of you on the approach to the patient with malignant pleural effusion. And I have to confess to you that I had a little bit of difficulty in getting this talk ready. It hasn't been since the MD days when I've talked about pleural effusion, and I had to struggle a little bit to get this talk ready. But anyway, I will not be talking about the management, which will be dealt with in the subsequent talks, but I'll be only talking about the approach. And this is the under the banner of the Academy of Lung Cancer, we are dealing with and talking about some unusual problems for which there are no drug sponsors, and usually they are not discussed in most lung cancer meetings. We'll try and see if we can one by one take up these issues. And this is the program of the day, and I hope by the time we finish in about an hour and a half, you'll all be a lot wiser. So I bring you greetings from the Shri Ram Cancer Center of the Mahatma Gandhi Medical College Hospital in Jaipur. And this is what I intend to do, talk a little bit on introduction, etiology, pathogenesis, clinical features, investigations. I will not talk about the management today because this will be dealt by the subsequent speakers and during the panel discussion. So we know that malignant pleural effusion is buildup of fluid and cancer cells in the pleural cavity. It's a common complication in a number of cancers. More than 25% of newly diagnosed pleural effusions are due to malignancy. 50% of cancer patients will develop a pleural effusion during the natural history of their disease. And approximately, this is data from the United States, 100,000 malignant pleural effusions are diagnosed per year. And once a patient has a malignant pleural effusion, the life expectancy is not very long, varies from 4 months to 12 months. The pathophysiology of the disease is like for fluid accumulation anywhere else in the body. Usually the pleural effusion contains malignant cells and about 15% of patients with malignant disease develop pleural effusion, and it generally indicates a poor prognosis. In about 2/3 of the cases, the pleural effusion is the one or the sole initial manifestation of the malignancy. 75% of cases of malignant pleural effusions are either tumors of the lung, breast, or are lymphomas. Malignant pleural effusion develops in primary or metastatic malignancies of the pleura by spread of the malignant cells within the intrapleural cavity, or by also sometimes infiltrating the lymphatics and leading to a collection of fluid between the pleural spaces. And we know that the physiological balance between the secretion of fluid in the pleural space and its reabsorption is the reason why malignant pleural effusion develops. As already been highlighted to you, the breast cancer and lung cancer form more than half of the causes of malignant pleural effusion. Another quarter is contributed by lymphomas, genitourinary cancers, and GI cancers. And sometimes in about 7 to 15% of patients, the cause of the pleural effusion is not known. Again, the prevalence of most common diseases, number 1 is lung cancer and number 2 is breast cancer. A host of interactions in malignant pleural effusion between the immune system, between the tumor, between the host have been described. A host of immune regulatory mediators have been described, and this is angiogenesis also plays a significant role in producing leaky pleural capillaries, and all these contribute and including several cytokines to the development of malignant pleural effusion. And this again is the complex interplay between the cancer cell and the pleural space and the pleural vasculature, which ultimately leads to malignant pleural effusion. Malignant pleural effusion impact the quality of life of the patient by producing significant dyspnea, cough, chest pain, and decreased motility, and the fear of impending respiratory failure and death, and it is an important symptom to be palliated. Once the patient develops malignant pleural effusion, the prognosis is not very good. About half of the patients die within a month, and 84% of the patients die within 6 months. This is old data, and this may have changed a little bit with the availability of better chemotherapeutic drugs and with the availability of other targeted agents. But as a rule of the thumb, the survival is about 10 months once a malignant pleural effusion is diagnosed. Patients who have a known cancer, who have exudative effusions, whose cytology is negative, these are poor prognostic factors. The role of the pH of the pleural fluid, the KPS performance status of the patient, again, also impact on the prognosis. Excuse me. What diagnostic tests we need to do? The most important is the chest X-ray. you need a minimum of 200 ml of fluid to be visible on a chest PA. However, 50 ml of pleural fluid could be diagnosed if you do a lateral decubitus X-ray. Then thoracic ultrasound is important. In addition to detecting fluid in the abdomen, it can also show you some important features like pleural thickening, diaphragmatic nodules or thickening, visceral pleural thickening, and pleural irregularities and nodularities, which again point towards the malignant etiology of the effusion. Computerized tomographic scanning of the CT scan is again highly specific but has low sensitivity, and it is difficult to separate benign effusions from malignant effusions, mesotheliomas from pleural metastasis by the CT scan. MRI scans offer better quality soft tissue images than CT scans, has a higher sensitivity to detect chest fall and diaphragmatic involvement, although the lung images have a lower quality as compared to the CT scans. Cytology of the pleural fluid is again extremely important, and the diagnosis of finding malignant cells in the pleural fluid is about 60%, much less for mesotheliomas and higher for adenocarcinomas. Once you get malignant cells in the pleural fluid, you can make a cell block, and on this cell block, you could do immunohistochemical studies and other molecular studies to progress on the diagnostic pathway. It is again important to differentiate benign from malignant effusions, and this is what we used to study in the MD. During the MD, pleural fluid LDH is high, protein is high, pleural fluid protein ratio is more than 0.5, and pleural fluid LDH is 2 to 3 times upper limit of normal serum LDH. And Hefner meta-analysis shows that pleural LDH of 1.5 times upper limit of normal, pleural cholesterol of more than 45, and pleural protein of more than 2.9. This is very likely to be a malignant effusion or a exudative effusion. As already mentioned, cytology is positive in about 2/3 of the patients, but if you do 3 consecutive pleural taps, then this can go up to 77%. Pleural biopsy is the gold standard for the diagnosis of these patients. Percutaneous pleural biopsy has a lower diagnostic sensitivity than cytology. As malignant parietal pleura infiltrates, they usually have a patchy pattern, and this is positive in only 50% of the patients. But if you include an ultrasound and do an ultrasound guided pleural biopsy, then this sensitivity can be significantly increased. Pleural manometry, again, this was a new term for me when I was preparing this presentation, is a procedure using ultrasound to identify a non-expandable lung through the calculation of pleural elastase. And this is important if you're planning a pleurodesis on your patient, and it can predict to you whether after the procedure, after a chest tube or after paracentesis, is the lung going to expand or not. Treatment options I'm not going to talk about today. Subsequently, we will discuss this. And with that, I thank you very much, and I hand over back to Dr. Prashant. Thank you very much.
Okay, thanks a lot for this overview. And I think what was, which has come out very well is that the pleural fluid needs to be set for cytology, and also cell blocks were discussed, and also the immunohistochemistry was discussed. So I think what we are doing in the current practice is that whenever there is a suspicion of a malignancy in the pleural fluid, we actually ask upfront for cell block.
Hello, Prashant sir. Hello, Prashant sir. Prashant sir has lost his connectivity. Hello, Hemant sir. Am I audible, sir?
Yeah, I can.
Yeah, Prashant sir has lost his connectivity. So we take these questions in the panel discussion, sir.
Okay, we'll do the
Okay.
questions in the panel discussion. Just continue, please.
Yes, yes. Thank you, Dr. Hemant Malhotra. I would like to invite our next chairperson, which is Dr. Rochan Pant and Dr. A.K. Chaturvedi. Dr. Rochan Pant is a director of radiology and imaging department from Sir H.N. Reliance Foundation Hospital, Mumbai. And Dr. A.K. Chaturvedi is chairman radiology and interventional oncology from Rajiv Gandhi Cancer Institute from Delhi. Over to you, Chaturvedi, sir.
Hello, Dr. Rochan. Are you there?
Sir, Rochan sir is not there.
Okay, right, fine. I just wanted to confirm if Rochan is around. Well, thank you very much for this wonderful academic meeting focused exclusively on malignant pleural effusion, management of pleural effusion in lung cancer. And I really appreciate the efforts put in by Dr. Hemant Malhotra and Dr. Ullas Batra to put this show together. And Dr. Hemant Malhotra has very nicely started off the topic, introduced the topic. As we know, the vast majority, more than half of the patients of malignant pleural effusion will be either breast cancers or lung cancers. The problem is the management, which is going to be discussed now by Dr. Abhishek Bansal, who is an interventional oncologist at our institute. He'll be talking mostly about the catheters, which catheters, when to use, and things like that. But broadly, the pleural effusion, it's a malignant pleural effusion usually is recurrent all the time. And if you have to do single time aspirations, it will be repetitive multiple times, causing a lot of inconvenience to the patient. So these serial aspirations are in fact very troublesome. So what one can do is one can put in an indwelling pleural catheter, and different types of catheters are available. Since they have to be in place for a longer duration, they can be tunneled, so they can be tunneled under the skin. So that is one of the recent advances that we practice at our institute also. And I'm not sure if Dr. Bansal is going to talk on pleurodesis, but that's also an option. And as Dr. Hemant Malhotra pointed out, that before you do pleurodesis at some centers, you might be doing the manometry. I don't think we are doing at our institution, but that is also an option. So I have just highlighted as to there is a problem of pleural effusion. Chemotherapy doesn't really always work. It may work. If chemotherapy works and the patient is asymptomatic, sometimes there may be no need for an intervention if the effusion is small. But increasingly, you develop the need for an intervention. And now I request Dr. Abhishek Bansal to please proceed with his talk and tell us about the types of catheters, which one, where, and how. Dr. Abhishek Bansal, please.
Thank you so much, sir. It's a pleasure to be present amongst such dignitaries in this meeting. I'm just sharing my screen. So is my screen visible?
Yes, it is. Yes.
Okay. Thank you so much, sir, for highlighting what.
So could you please full screen, sir? Could you just full screen it, sir?
It's showing full screen in my. I'll just stop sharing again and.
No. Are you in the office itself, because you have that dual monitors? In that case, this problem always comes.
No, so I'm doing it from a laptop, sir. Is it full screen now?
It's not. You make it presentation mode. Make it presentation mode. Or press F5. If you press F5, it will become full screen.
Yes, sir. Just a second. I'm sorry for this trouble.
See, if you press F5, something happens.
Is it full screen now, sir?
Well, we see your screen with all the other slides on the side.
I've stopped sharing and
So could you just full screen it, and then from Alt tab you can just share it? Hello, Abhishek sir.
I think if there's a difficulty, you can just proceed as it was projected. We still get to see your slides, and fairly well. So if you're not able to make it full screen, just proceed. Dr. Abhishek?
Sir, Abhishek sir has lost his connection.
Oh,
I'm here. I got muted.
Just give me a minute, sir. I'll call him. Sir, you can go ahead with this, sir.
Is it full screen now?
it's not full screen, but
No, sir,
Abhishek,
you can go ahead.
you can go ahead.
Okay,
We
okay.
can see your slide,
Right,
and we
sir.
also get to see the next slide.
Right, sir. So thank you for including this topic, actually, which is a common cause for concern and a confusion that what best to do for such patients. And it's a beautiful picture that was given to me in the brochure of management of pleural effusion. And I've taken the liberty to reshape these two boards on both sides. And I've shown what are the various options that we can use for such patients. One could be a pigtail and one could be an indwelling pleural catheter, which Dr. Chaturvedi already talked about. And so this is one review paper published in the Lancet Respiratory Medicine 2019 that talks about management of malignant pleural effusion, keeping the floodgates shut. And the topic for today is just like this one, when we are offered multiple choice questions in terms of which is the most appropriate answer, and it can get as difficult as the current slide. We know that almost 15% of lung cancer patients develop malignant pleural effusions, and it is a poor prognostic factor. There are various guidelines ranging from American Thoracic Society to the Society of Thoracic Radiology, thoracic surgeons, and even various European guidelines that I have referred to in this particular talk. The treatment goals are mainly...
Sir, your slides are not moving, sir. Sir, your slides are not moving, sir.
It's not advancing.
So could you just share the slides on this email address, sir? I'll just put it in the chat box.
Yeah.
Sir, I posted in the chat box.
Yeah.
So have you shared it, sir?
Yep, just a second. Yep, send.
Yes, you can share the slide.
Yes, sir. Doing the same thing.
So in the meantime, I'll just talk about the gist of the talk. So there are a lot of options in terms of how a patient should be tackled with a malignant pleural effusion. The starting point, as Dr. Chaturvedi said, is probably we will do a pleural fluid aspiration, which could be done through a single needle or a small catheter. This is done, as Dr. Malhotra also said, to send fluid for analysis. And depending upon what malignancy we are dealing with, the chances of picking up malignancy are dependent on that. And after that, we have to look for lung re-expansion and whether the fluid is reaccumulating and how fast it is reaccumulating. Because these are two factors that will determine how to go forward, whether the patient is suitable for IPC, that is an indwelling pleural catheter, or a simple pigtail followed by pleurodesis. So that's how we majorly differentiate between...
I have not yet received their emails.
Sent it. rrcg.yash@gmail.com.
Yes, received, sir. Received. Just give me a minute. You can go ahead, sir.
So that's how we determine, and I've taken some of my data and slides from the American and European Society of Thoracic Oncology, thoracic surgeons, pulmonologists, and Society of Thoracic Radiology, and some certain slides from up to date as well. So yes, so yeah, next slide. Yeah, next slide. Next slide. Next slide. So the treatment goals mainly focus on how we go forward, and the focus is palliative. Treatment should mainly focus on patient-centered goals of therapy, that is a sustained symptomatic relief, improvement in quality of life, acceptability of an intervention, affordability, and preference for a less invasive procedure. Next slide. The decision for pleural intervention depends upon presence of respiratory symptoms. The most common are the dyspnea and the chest discomfort or cough. Depending upon this, it could be either a symptomatic malignant pleural effusion or an asymptomatic one. Next slide. The first step is actually therapeutic thoracocentesis, and it is typically performed using a needle, a catheter, under ultrasound guidance. The thoracocentesis determines the symptomatic response to drainage, the ability of the lung to re-expand completely or partially, and the rate of subsequent reaccumulation, all of which will actually inform future more definitive treatments should the effusion reaccumulate. Next slide. Almost 50% of these effusions would reoccur, and almost 2/3 of them would reoccur within a month. So various options are there. It could be a repeat thoracocentesis, indwelling pleural catheter, pleurodesis, combination therapies, a partial or complete pleurectomy, or a pleuroperitoneal shunt. The below ones are actually the definitive procedures that actually result in fewer subsequent pleural procedures, fewer emergency department visits, fewer hospital admissions, and fewer pneumothoraces. Next slide. So these are the various options that actually are seen, that actually are available to us. The most common one is the chest catheter drainage. And however, we need to know that most effusions will recur after catheter removal. Chest catheter drainage with pleurodesis, the response rate is 60 to 90%. Thoracoscopy with talc insufflation, again, the effusion is similar frequency as a chest catheter drainage or talc pleurodesis. Long-term indwelling pleural catheter, it leads to control of effusion and improved symptoms in most patients. And some patients may even have a spontaneous pleurodesis. That percentage is roughly around 40%. You can use the long-term pleural catheters even for pleurodesis subsequently. The pleurodesis doesn't happen spontaneously. Next slide. So the choosing amongst the options, the optimal option is unclear. Considerable variation exists in practice depending upon where you are practicing, and the optimal solution should be tailored to the individual patient. Next slide. The factors in play that need to be considered is whether the lung is expandable or non-expandable. If a lung is expandable, the patient can undergo several therapies. However, if it is a non-expandable lung, then it is limited to a IPC drainage only. If it is a rapid reaccumulation, you need to go for a definitive drainage, either a pleurodesis or a catheter. However, if it is a slow reaccumulation and the patient is kind of responsive to tumor therapy, then you can actually do a single-time thoracocentesis again as well. Similarly, the third point is about responsiveness to the anti-tumor therapy. For tumors which are actually responsive to chemotherapy or other systemic agents, again, avoiding pleurodesis or a long-term catheter can be reasonable because these are the patients who would respond better. However, if we think that the patients would not respond to the systemic treatment, then again, drainage is an option for such patients. Next slide. The patient prognosis and functional status is again important because if a poor prognosis or poor FS patients would definitely prefer a minimally invasive procedures. Again, institutional resources, expertise, and physician preference is something that also constitutes, because especially if you look at the Western countries, IPC is more popular in US, whereas a pigtail catheter followed by pleurodesis is more popular in Europe. In terms of patient preferences, this is important because if a patient has an anticipated survival of more than 2 months, then pleurodesis can actually be carried out in a single definitive procedure rather than patient having to live with the inconvenience of an indwelling catheter that requires intermittent drainage at home. Again, some patients may choose IPC because pleurodesis has got certain risk factors such as local pain, low-grade fever, chest infections, and even really respiratory distress and increased time in the hospital. So therefore, informing patients of local facility and professional charges for each approach helps the patient to decide, and it is better that you let the patient decide what is best option for them. Another important factor in our country, at least, is that the patient's family or support system should be there to care for IPC at home. Next slide. So in terms of an expandable lung with rapid reaccumulation, IPC is definitely something that is an option. It provides good symptomatic relief and can induce spontaneous pleurodesis up to 40% of the patients. Patients spend little time in the hospital and is done in an outpatient procedure. It is best suited for patients who have got a shorter survival, like less than 2 months, and for patients who prefer outpatient management and a minimally invasive option. It can be also used for patients who have failed pleurodesis initially and does not preclude subsequent pleurodesis if desired. It can also be combined with talc pleurodesis as already explained. However, the disadvantage include a longer dwell time that may be weeks or months versus days of pleurodesis and infection. And it also requires the patient or caregiver perform drainage at home. Next slide. So in terms of length of stay and reduced interventions, so this paper is a meta-analysis of 5 trials that almost include 550 patients, and that confirmed that compared to pleurodesis, IPC resulted in a shorter hospital length of stay and reduced frequency of repeat interventions without any survival benefit. However, a shorter length of hospital stay may not be clinically meaningful because the patients are actually draining the fluid at home, and so that's not taken into account. In addition, 3 major randomized trials found no difference in post-procedure dyspnea, chest pain, or quality of life scores between the 2 groups. Next slide. In terms of complications of IPC, the bleeding, catheter blockage, catheter fracture and removal, tract metastases, and in particular infection at the point of insertion along the catheter tract or within the pleural space can be quite problematic for the patients. Infection in a meta-analysis of 5 trials, IPCs resulted in an increased risk of cellulitis compared with pleurodesis alone. In terms of loculations, a lot of patients can actually develop catheter-related infection, which may lead to further loculations, and actually then the catheter cytos are also not able to drain the fluid that well. I'll come on to it, how we can manage it. Catheter fracture, bleeding, and pneumothorax are another risk factors. Next slide. So localization is something that we should not take it lightly, because majority of these patients would have indwelling catheters, and howsoever we may try hard in terms of the population that we have in India, until unless the patient and his family are from a upper socioeconomic strata, from a middle low economic strata, we have seen that these patients land up with infections and multiple loculations in the pleural space. Now, these patients are not amenable to any treatment except for instillation of streptokinase. Mind you, the first injection is pretty well tolerated by the patient, but the moment you plan to do it second time or third time, now you're looking for trouble, because these patients can have allergic reactions and severe allergic reactions like an anaphylactic syndrome. Urokinase was something pretty cheap and pretty good, but it is no longer available in India. And again, TP is something that can be done, but the cost is a major hindrance. Next slide. So this is something that we can actually do. Again, we can actually push in a wire through the IPC, and this is how a wire actually goes into IPC, and these septations can be broken through the wire also. Next slide. But again, all these things actually lead to a troublesome course for the patient and leads to frequent hospital visits that was not encountered in that meta-analysis that I talked about initially. In terms of pleurodesis, it is an appropriate alternative to IPC alone, and it is actually suitable for patients with an expandable lung who have a reasonable survival more than 2 months or at least 2 to 6 months, and who prefer a more definitive and rapid procedure that minimizes future interventions. Pleurodesis is not suitable for patients who have a shorter anticipated survival, less than 2 months. It can be performed through an IPC or a normal chest tube only. The main advantage is that it is more effective within a shorter time frame than IPC alone. However, the main disadvantage is the post-procedural pain and a small but potentially serious risk factor of respiratory complications, particularly when talc is used as a sclerosant. Next slide. The chest tube size, in terms of, there's enough data now that the 12 French chest tube size is as good as 24 French. Both are similar in terms of the overall data. And actually large bore chest tubes, previous slide, please.
Previous slide.
The large bore chest tubes actually cause more patient discomfort. And again, a shorter duration of chest tube post pleurodesis. If we remove the catheter post 24 hours versus 72 hours, there was no significant difference in terms of the success of pleurodesis. So it is a standard practice now that once we do a pleurodesis, the catheter is removed the very next day. Therefore, the patient's hospital stay is also reduced. Next slide. So what about the non-expandable lung? We talked about the expandable lung where we had 2 options. So these are the patients that are not suitable for any type of pleurodesis, and the options are only limited to drainage with an IPC. Ultrasound may actually guide IPC placement into the largest pocket of fluid to maximize symptomatic relief. And patients who decline IPC or in whom a short life expectancy is anticipated, repeat thoracocentesis can be an option. Next slide. So this actually table I've taken from UpToDate that talks about both advantages and disadvantages of indwelling pleural catheter versus talc pleurodesis. Both would lead to improved symptoms. The success rate with pleurodesis is more with the talc pleurodesis versus IPC alone. The drainage duration is shorter with talc and longer with IPC. The infection risk is again more in IPC versus talc. The outpatient drain care again need to be taken with IPC and is not required with a pigtail and talc. The length of hospital stay is 0 in IPC. Patients can be undergo these procedures on OPD basis. And whereas with talc pleurodesis, you need to admit the patient for at least 3 to 5 days. Again, patients who have a shorter lifespan, they are the ones who can be opted for IPC. And patients who we feel there's a longer lifespan, generally talc pleurodesis can be preferred in those patients. Again, pleurodesis can be eventually performed through IPC also if spontaneous pleurodesis fails. Next slide. So this is actually a simplified management pathway. Once we deal with the malignant pleural effusion, we do a therapeutic aspiration. If there is improvement in dyspnea, we see whether there is a lung re-expansion. If there is no lung re-expansion, we straight away go for IPC. However, if the life survival is less than 1 month, it is better to go for repeated thoracic thoracocentesis to avoid any discomfort to the patient. However, if life survival is more, then we have a patient choice, either IPC or a pigtail followed by talc pleurodesis. IPC again, if patients prefer accelerated pleurodesis, we can offer aggressive drainage regimens and talc installation through the IPC as well. Next slide. So this was all about how we choose and which catheter to be opted for, and depending on what patients. But again, this is not a comprehensive presentation. A lot of work is going on, and this is a slide that I've again taken from UpToDate that talks about a number of trials that are going as of now across the world to actually find the answer which is the best catheter, when to use it, how to use it, and where to use it. Thank you.
Thank you very much, Dr. Abhishek. That was really a wonderful talk on management of malignant pleural effusion. There is a question now popping up, and I can read it straight away. Role of urokinase. I think Dr. Abhishek Bansal did show a slide. He mentioned it briefly. And Dr. Abhishek Bansal, do you want to answer that role of urokinase?
So yes. So again, all these agents are very useful whenever we have multiple septations. And it's always a good practice to actually break all the septations with either a streptokinase, urokinase, or TPA. But unfortunately, urokinase is no longer available in India. Suddenly, all the companies have stopped producing it for, I don't know what's the issue. So that leaves us with only streptokinase and TPA as the option.
And the cost is an issue with the TPA. So that is also well known. There was another question which I noted down, and the question was, why pigtail and why not ICD? I mean, why would you choose pigtail at all?
So I've shown that slide, if you would have noted. So there's a randomized data now that a 12 French catheter is as good as 24 French ICD in terms of overall emptying out of the pleural space, with the lesser patient discomfort with a 12 French pigtail rather than an ICD. So we are not dealing with empyema over here. So this is just a malignant pleural effusion. And a 12 French pigtail is as good as a thicker ICD. That's been proven beyond doubt in the paper that I had already mentioned in my talk.
So actually, the aim is only to minimize the size of the pigtail catheter so that patient discomfort is less, because data shows and literature shows that the results are almost equivalent. There is a comment, it gets blocked with coagulum. The pigtail, does it get blocked with coagulum?
So, sir, in our experience, all catheters get blocked, even the IPCs, which are 16 French, multiple side holes. Dr. Rajiv sir is here. He has more experience with IPCs and he can vouch for it. So I think eventually all catheters get blocked. But our aim with pigtail is, when we're putting a pigtail, to empty out all the effusion, then go for pleurodesis the next day. So don't take pigtail in isolation. So we use it with pleurodesis. So you can do pleurodesis with IPC also, but then that adds to the cost of the patient. So imagine you're subjecting the patient to a IPC cost first, then the pleurodesis again. So I think it doesn't make sense.
There's another comment, and I think I missed it. It's gone off. And it was that betadine pleurodesis is easier and simpler.
So actually, sir, we have used talc slurry very comfortably with normal 12 French pigtails. We haven't had any issue. They don't get blocked with talc. yes, betadine can also be used, but the overall success rate of talc is better than betadine alone. So definitely in terms of efficacy of pleurodesis, talc is better than betadine, sir.
I think we are running out of time, but just I think one more question, one or two. Role of NaC or bicarbonates?
Personally, sir, I haven't had any experience, and we have an institute.
Dr. Rajiv is here. Dr. Rajiv Goel, would you like to comment on that?
No, there is no role for bicarbonate for pleurodesis. And just to refer to the earlier question about betadine, 20% or 10% betadine has been used by a lot of people, but the Indian trials have also shown that the success rate of betadine is of the order of about 65 to 70%, while TAL gives you a higher, rate of success. So, having said that, betadine is a cheap alternative. It can be used in those patients who are not sensitive to iodine. And the other advantage of betadine is that you can reuse it if required, while talc most often is not sort of reused. So in that sense, if a patient fails on one pleurodesis, then you may attempt it again with betadine, which is not often the case with talc. So in situations where the patient can't afford it, talc does cost about 5,000 rupees. So, if a patient can't afford it, then yes, povidone iodine can be used.
I think there is a lot of interest on pleurodesis because many more questions have popped up. And one simple question is, which is the best modality, which is the best way to do pleurodesis? What would you prefer if you have choice and you want to use just one? Would it be talc slurry or?
So it will be talc slurry for me, sir.
Yeah, sure. I think talc slurry would be the answer because
right.
In the sense that
so the other question is mitoxantrone pleurodesis. I myself don't know what it is. Mitoxantrone pleurodesis.
I think a lot of agents have been tried, but talc is the agent which is now universally sort of accepted as the best. So people have tried doxycycline, tetracycline, bleomycin, quinacrine, all kinds of things have been tried. But amongst all these agents, the talc, scores above all. Yeah.
Thank you very much, Dr. Abhishek Bansal. Thank you, Dr. Rajiv Goel, and thank you to all the participants for asking questions. Many more questions are popping up every now and then, and I have been hinted that they can be discussed during the panel discussion. So I'll hand over back to the organizers, please.
Thank you, Dr. Bansal and Dr. Chaturvedi, sir. I would like to invite our next chairpersons, who is Dr. P.S. Shahjahan and Dr. B. Jayaprakash. Dr. P.S. Shahjahan is a President, Academy of Pulmonary Critical Care Medicine, Professor of Pulmonary Medicine, Government TD Medical College, Alappuzha, Kerala. And Dr. B. Jayaprakash is a Professor of Pulmonary Medicine, Government Medical College, Trivandrum, Kerala. Over to you all, sir.
Thank you, sir. At the outset, on behalf of the President, Dr. Professor Shahjahan, and myself is the Secretary, Dr. Jayaprakash, and all members of Academy of Pulmonary and Critical Care Medicine, APCCM, which is actually the Pulmonologist Society basically in Kerala, but we have members all over India. We have more than 700 members. And we express our sincere thanks to the Academy of Lung Cancer, especially to Dr. Hemant Malhotra and Dr. Ullas Batra, they are the program directors, and to Rakesh Reddy, the program convener, for giving us the golden opportunity to be associated with Academy of Lung Cancer in this fabulous webinar series. Thank you once again from our bottom of the heart. So coming to the topic proper, medical and surgical perspective of thoracoscopy. Actually, thoracoscopy is an investigation which is more than 100-year-old. And it remains, and now is the gold standard for the diagnosis of pleural effusion, especially malignant pleural effusion. And to narrate about the medical and surgical perspective and aspects of thoracoscopy, we have an eminent speaker, Dr. Rajiv Goel. He is the head of the Department of Respiratory Medicine, Rajiv Gandhi Cancer Institute. And Rajiv Goel sir is one of the star in our pulmonology conference, NAPCON, and all other respiratory conferences. With due respect, I invite Dr. Rajiv Goel sir to start the session.
So So if you will, thank you so much, Dr. Jayaprakash, for this very kind introduction. And thank you, Ullas, and the other organizers for inviting me here. It's a pleasure to be here, and I am impressed by the number of participants and the active interest being shown by so many delegates. And so I'll start. If I'm allowed to share my screen, then I can go ahead and do that.
Yes, sir, you can.
Yeah, so, okay, I think, is my screen visible now?
Yes, sir.
Yes, sir.
I'll now try to make it full screen. Okay, now.
Ready, sir. Ready, sir.
Yes, sir.
Very nice.
Well,
Go to the first slide. Right. So basically, let me just say that medical thoracoscopy is something which has actually been a game changer as far as diagnosis of undiagnosed pleural effusions is there. And we know for a fact, all of us who have practiced medicine, that when you deal with pleural effusions, many a times you come to a dead end when you find that the pleural fluid aspirate is not giving you the diagnosis. So thoracoscopy involves the insertion of a rigid or a semi-rigid telescopic device into the pleural cavity to inspect and to take biopsies and to perform therapeutic procedures like like Pleurodesis. And also you can help to break adhesions. Sometimes in a patient, in some cases you may do a sympathectomy or a pericardial window creation, but that is for the experts. So normally a medical thoracoscopy means that you do it with a single port, while a surgical video assisted thoracoscopy surgery is done through multiple ports. Now, the procedure, as Dr. Jayaprakash said, it was described years ago by a Swedish internist, mind you, who used a cystoscope to inspect the pleura, and he used it to break adhesions in a patient who had tuberculosis. After that, the procedure, didn't pick up so much, but in the late 80s and 90s, it became very common again, and it was revived by several people. And now it has become a standard practice. And now with the advent of the semi-rigid thoracoscope, more and more, pulmonologists are taking to it. So what is the basic difference between medical thoracoscopy and the VATS procedure? The medical thoracoscopy can be done by, by the internist and by pulmonologists. It is done under conscious sedation, unlike the VATS procedure, which has to be done under GA with a double lumen endotracheal tube. Thoracoscopy can be done under conscious sedation in a bronchoscopy suite through a single port, and obviously is less expensive and less morbid for the patient. Now, the usual diagnostic approach when you have a patient with pleural effusion is to do a thoracentesis, look at the color, the turbidity, the smell, etc. of the fluid, and also look at the pH, see if it is bloody, look at, see whether it is chylous in look and whether it has high triglycerides, and also subject it to look at, the protein and sugar to find out whether it is a exudate. And you also get the LDH done and the ADA, the adenosine deaminase, which helps you to decide whether it might be tubercular. The cytology is done on the pleural fluid, which tells you about the presence of abnormal cells and inflammatory cells, and you may also subject this to microbiological analysis. However, when you with this analysis, you are able to make the diagnosis in about 60 to 80% of the cases. You may tell whether it's an empyema, whether it's a hemothorax, whether it's a transudate because of any systemic illness. Sometimes you are able to tell whether it is TB with the adenosine deaminase is high and you have an exudate. If the cytology is positive, then yes, you can say it's because of malignancy. However, many times you don't have a diagnosis, and then you need to sample the pleura, which means that you need to take a pleural biopsy. Now, this has been traditionally done by a closed pleural biopsy, or lately by a CT guided or an ultrasound guided pleural biopsy. But the thoracoscopy has changed that because the yield of thoracoscopy is much higher, as I will show you. So the closed pleural biopsy used to be done with a Copes or a Abraham needle. Now we have stopped using these needles altogether since the thoracoscope has come in. Sometimes we do use a fine fine needle or a true cut needle when you have an obvious mass like lesion or a nodule on the CT scan showing a pleural based mass. So there you may use a true cut or a fine needle aspiration from that. Otherwise, the closed pleural biopsies are now not done. You can use it to diagnose TB and malignancy, as I said. If you have CT guidance, the yield goes higher. The advantage of thoracoscopy or blind biopsy, of course, is that you do a complete examination of the pleural cavity and lung surfaces. A biopsy from the parietal pleura can be done under direct vision. And you can, not only do a diagnostic biopsy, but you may also do a therapeutic procedure like a pleurodesis in the same sitting. It allows you to, prepare the pleural surface, optimally for a pleurodesis. And you can also use the thoracoscope to break adhesions and allow the lung to expand. So, these are several advantages of the medical thoracoscopy over the blind pleural biopsy. Now, if you look at the, this is a very large study. This is from the British Thoracic Society guidelines, where they pooled data from about 1,300 plus cases. And they found that the 60% were positive by, malignancy by a single diagnostic aspiration. However, in mesothelioma, this positivity fell lower, only about 32%. And a closed pleural biopsy increased the yield by about 7 to 20%. In TB, it diagnosed about 80% of cases. However, when you did a thoracoscopy, they found that in a meta-analysis, the yield of malignancy was as high as 93%, about 90% in mesothelioma, and 100% in TB. So in a country like ours, if you have an undiagnosed pleural effusion, if you are able to offer a thoracoscopy to such a patient, then that is the ideal, answer in terms of the yield. If you look at this chart, which is very interesting, because if you have a needle biopsy on one side, a fluid cytology and a thoracoscopy, you find that cytology and needle biopsy together give you the answer in about 75%, but thoracoscopy gives you the answer in almost 96%. And if you combine all these three, you can have the answer in virtually all patients. So basically, what is medical thoracoscopy? What kind of training does it require? Well, the knowledge of pleural and thoracic anatomy is a must. So normally all, trained pulmonologists now are expected to be able to do a thoracoscopy. You should be able to interpret radiographic images. And then if you do about 20 such procedures in a supervised setting, then you are ready to go. So it doesn't take long to learn, and it's a procedure which you can maintain competency if you do about 10 procedures a year. Now, what are the indications for medical thoracoscopy? I already said that if you have an indeterminate pleural fluid, if you have an abnormal pleura, if you have a need for pleurodesis, then a thoracoscopy can be done. Also, if you have adhesions, then an experienced thoracoscopist can actually use the thoracoscope to break adhesions. It has been used for taking biopsies from the lung, but we'll not get into that. Contraindication, the main contraindication I would think is that if the pleural space is not seen, that means if there's no fluid, or if the pleural space is adherent, that means the pleura and the parietal and the visceral pleura are adherent, then you can't do a thoracoscopy. Of course, you can't do it if there's uncorrected coagulopathy, hemodynamic instability, respiratory failure, etc. So those are the contraindications. The instruments are fairly simple. You have a thoracoscope with a telescope. You insert a, I will show you the technique. You insert a trocar through a cannula, and then you can use these forceps to take biopsies. And this is an insufflator for doing pleurodesis, and we'll come to that. This is the new device which I was talking about, the semi-rigid thoracoscope, which handles just like a bronchoscope. It is more expensive, but it can be used very effectively to take biopsies under vision. And because it handles like a bronchoscope, pulmonologists find it very simple to use. In fact, you can use the same processor and light source, etc., for using this instrument. So normally, if you have a patient with a chest radiograph like that, a good thing is to do an ultrasound, because an ultrasound will show you where the fluid is, and you can mark an area just above the diaphragm where you can insert your thoracoscope. So normally you make an, do an ultrasound examination before the thoracoscopy, and then you try to, put the patient in the non-dependent position with the pleural fluid up, so that you find the appropriate position for doing the thoracoscopy. Now let us see. So basically you start off just like a normal, you clean and drape the patient because it's a sterile procedure. You clean and drape the patient. You insert a needle into the pleural space, the marked by the ultrasound, to confirm that there is free fluid there. Then you start just like an intercostal tube. So you'll make a small incision and make sure that you do a blunt dissection to reach the bony cage. And there you will do, further blunt dissection with a forceps, and then insert this forceps to go into the pleural cavity. You can see here the forceps being inserted into the pleural cavity there. And once we do that, then we put in some dilators just to sort of dilate the pleural hole that has been created. These are actually the Hagar dilators which are being used here, which are normally used for cervical dilatation. So the surgeon who taught me thoracoscopy showed me how these Hagar dilators can be used to do this. You can also do this with the forceps. So once this is done, you insert the trocar for the thoracoscope, and this is the trocar, the thoracoscope in one assembly with the forceps inside and with the telescope. This telescope is attached to the camera. So you can see the trocar has been put in. There was a lot of pleural fluid in this patient, so it is coming out under pressure. The tap is open to the atmosphere. So as the pleural fluid goes out, air rushes in so that the lung remains collapsed and there is no re-expansion pulmonary edema, even though you may be taking out a large amount of fluid. Once the trocar has been inserted, the cannula is left inside, and then under vision you can actually aspirate the whole fluid. And once you do that, you can see here the diaphragm on one side, the collapsed lung on one side, and you have a brilliant view of the pleura. And you can actually see the pleura under direct vision. You can see this nodule on the diaphragm here and several other nodules on the parietal pleura. So when you have a vision like this, you forget about closed pleural biopsies because you can take large chunks of these nodules, and no pathologist is going to complain when you take biopsies like this, because you get huge amounts of tissue which can be subject to all kinds of analysis, whichever the pathologist wants to do. So basically, thoracoscopy has completely changed the scenario as far as undiagnosed pleural effusions go. You can see here this whole nodule being taken out in toto by the large forceps. So this is what thoracoscopy offers. Now, okay, let's go to the next slide. Yeah. Now, once the thoracoscopy has been done, you can also do a pleurodesis. So once you can see here talc being insufflated. This is asbestos-free talc. There was a discussion just before this as to which is the best agent. This is a good agent to use. Asbestos-free talc is not too expensive. It's about 5,000 rupees. And you can use the thoracoscopic port to spray this talc under vision over the entire parietal pleura and the visceral pleura, so that you will get good apposition once the tube is there and the air is drained out. So you can see here a snowstorm of talc being created and the talc being sprayed all over the pleural surface to give you a complete whiteout of the pleura. Now, once that is done, a tube is left inside. Again, the advantage of the thoracoscopy is that you can put the tube exactly where you want it in the posterior costophrenic angle, and a good drainage can be achieved. And if there are any adhesions, those also can be broken with the thoracoscope. So the risks of medical thoracoscopy: you can have bleeding, subcutaneous emphysema, air leak, infection of pleural space. But mind you, all these are actually very, very uncommon. Now, the agent, as I said, we have already discussed that, so I won't go into it again. Talc is good. Now, some cases for you. So this is a patient who had a recurrent pleural effusion, chest pain and dyspnea for 2 months, and you find that the pleural effusion was negative in cytology. Mind you, sometimes you can have, a pleura completely studied, and yet the pleural cytology you find is negative. Now, this patient had a high LDH, low ADA. You can see the whole pleura completely studied. And when these biopsies were taken, not unsurprisingly, it turned out to be a malignant mesothelioma. So, mesothelioma, we know now that the cytology, for some reason which is not clearly understood, can be actually quite low, and you can have such a patient. Another patient, Okay, now this is, sorry. Yeah, another patient, 36-year-old, breast, carcinoma with a recurrence, pleural effusion, refilling after repeated thoracentesis, pleural fluid, lymphocytic exudate, negative cytology again, which is why the thoracoscopy had to be done to confirm. You find that again the pleura is actually, studded with nodules, and once you go inside, you find that the whole pleura is studded with nodules, and not unsurprisingly in this case, it was a metastatic carcinoma, and a talc pleurodesis was done, which was successful. So, this is another thoracoscopic picture that I was showing. And sometimes, you have patients like this, if you see very carefully, you can see here these very small nodules. So this patient had pericardial effusion, fever, chest pain, and lymphocytic exudate with a normal ADA. You can see these small nodules. Now, the biopsy, when it was done, it showed caseating granulomas with occasional AFB. Now you can see that how when you have such scattered kind of involvement of the lung, of the pleura, there is no hope that a closed pleural biopsy or a CT guided pleural biopsy is going to give you that answer. So pleural biopsy with a thoracoscope can give you an answer under direct vision. And of course, this is the garden variety of tuberculosis where the whole pleura is studied, and not unsurprisingly, it showed caseating granulomas. So with that, I come to the conclusion of my talk that medical thoracoscopy, or what is now called as pleuroscopy also, is a minimally invasive procedure with a superb yield. It has the advantage of being performed under local anesthesia with sedation. It can be used effectively for therapeutic procedures like pleurodesis, breakage of adhesions, and for proper placement of chest tubes. Success of the procedure depends on a proper selection of the case. It is a safe procedure with minimal complications. Training is required, but it is simple and easy to learn and not too difficult to maintain your competency. Thank you very much. Thank you, Ullas, and thank you all the others for giving me this opportunity. And thank you, my chairman, sir, Mr. Jayaprakash, Dr. Jayaprakash, for allowing me this 20 minutes. Thank you very much. So,
Hello.
Yeah.
Dr. Shahjahan, are you there?
So, Professor, thank you, Dr. Rajji Goyal, sir, for a wonderful presentation. And what you said is correct. Actually, the revolutionized the scenario. I was remembering my PG days where we pleural biopsy with very poor results. So now there are some questions from the audience, like
sorry, I can't hear.
Jayaprakash, sir, you can take the question, sir. I think so. Shahjahan sir's internet connectivity is a bit low.
Okay. Rajesh sir, from Rajesh Sarnagar, there is a question. Would you prefer pleurodesis during a diagnostic thoracoscopy if the lung is expandable in malignant pleural effusion?
The answer to that is yes. However, I have Ullas sitting there who often doesn't allow me to do it. So many a times, the oncologists have this sort of fear that sometimes you might want more biopsies, or if the biopsy doesn't prove adequate. Although my feeling is, my own personal sort of preference is that if a patient shows very clearly that there is malignant spread, and like some of the cases that I showed you, then one can and should go for a pleurodesis. However, if for some reason the pleurodesis is not done in the same sitting, it can always be done with talc slurry subsequently once the lung is expanded, and that gives you almost equally good results.
Sir, Rajesh Sarnagar sir is again asking, is there any difference in outcome when talc pleurodesis is done via thoracoscope and done through chest tube?
Yeah, so I just answered that. I just answered that with that the pleurodesis with the talc slurry through the tube can also give you equally good results. The only thing is that it is much more satisfactory, I would say, for the pulmonologist to see the pleura being evenly kind of the powder being evenly spread all over the pleura, to make sure that there are no loculations subsequently, and the pleura will be uniform adherent. I think people have tried to compare, have shown that the thoracoscopic pleurodesis is slightly superior to talc slurry, but talc slurry is not way behind.
Sir, one more
question. I have a question. Okay, JP, I have a question, sir.
Yeah.
Suppose you are suspecting malignancy and you did a thoracoscopy and you find the pleura is apparently normal. What will you do?
Pleura is absolutely normal.
Apparently normal. What will you do?
Under those circumstances, what we do is we try to look at areas which are, a little more vascular. We try to look in some of the hidden areas over the, near the diaphragm. And sometimes you may have, some nodules over the diaphragm or over the lung, which an experienced thoracoscopist can actually, undertake taking biopsies from. However, I would not recommend it for the people who are learning the procedure, because normally we parietal pleura. But in those situations where the pleura is completely normal, then you may consider taking biopsies from areas which are looking, which are more hyperemic, or trying to take biopsies from any nodule which is apparent on the diaphragm or the lung. I may say that, the newer thoracoscopy, the semi-rigid thoracoscopy, they are coming up with the NBI. So with the NBI, you can actually, narrow band imaging, you can actually look at the pleura again with the NBI image and try to look for those areas which are, showing a little more, which are looking abnormal, and then one can take biopsies. I hope
Sir,
that
have you used cryo? Goel sir, have you used cryo also through the thoracoscope for
so that's a
also
very good
taking biopsy?
Yeah, that brings up another aspect to this. We have used cryo in those situations where the pleura is, a little firm and flat, plaque-like, where instead of friable nodules, you have plaques. In those situations, we have found that taking biopsy sometimes can be difficult, and the biopsy forceps tends to slip off the surface. In those situations, we have used cryo to take, to pluck out pieces of pleura, and that has sometimes, given us a proper yield.
Sir, your opinion is not very interesting comment. We were used to do pleurodesis with autoclaved Johnson baby powder via chest tube in my PG, and that also with a wonderful outcome. Your opinion, sir?
Well, I think that my recommendation would be against it, because what is happening is that, the history of talc is such that when the talc was used for pleurodesis in America, they found that they were getting few cases of ARDS. And the reason for that was that the talc was ungraded. There was different particle size of the talc. So the Europeans were using the talc which is of a high grade, which means that all the particles are more than 5 microns. So you find that if you have smaller, talc particles, they will get into the bloodstream and they can go and lodge into the lung and cause ARDS. So my feeling is that this Johnson talcum powder, we do not know what is the grade of the talc. So, that is one thing which can be detrimental to the patient. You don't want to have the patient get into ARDS. Second thing is that the talc, we have to be sure that it is asbestos free. Because although, one may argue that in malignant pleural effusion, you are doing pleurodesis for, patients who don't have long to live. So asbestos free or not doesn't make too much of a difference, because they are not going to get mesotheliomas. But, we are also using pleurodesis in patients with recurrent pneumothorax and those situations. And sometimes, in rapidly refilling transudative effusion. So that is why talc, which is asbestos free, is recommended for pleurodesis. So that is the reason why I would not, sort of recommend using Johnson talcum powder, although it is very cheap.
I think there are some ethical issues also, sir, no? Using this,
Yeah, so ethical issues, because you have not tested it in proper controlled. I think PGI people, they did one study like that. They have done a study like that, and they showed that it is effective. But then you have to be also sure that the talc has to be of a uniform grade. So even they are not using now that the cheap talc.
Well said, sir. Sir, another question: do we ask patient to change the positions after pleurodesis?
No, that was thought earlier that should be done. But now we are not doing that. It is seen that by capillary action, the chemical sclerosant, whatever you are using, it spreads all over, and you don't really need to, put the patient into different positions to achieve best pleurodesis.
Okay. Sir, another question, one more question we can take, I think. Sir, in case of cytology negative pleural effusion, which is otherwise low ADA, exudate and hemorrhagic, and if patient is not fit for thoracoscopy, should a pleural drainage with the pleurodesis be done without histocyto proof of malignancy?
See, this is a very, very, you can say this is a highly individualized thing, in the sense that you are talking about a patient where the possibility of malignancy is high, the pleural fluid is causing. So I would imagine, suppose this patient has got cancer elsewhere in the body. I imagine if you are, talking of such a patient who has cancer elsewhere in the body, has got a CA breast, has a pleural effusion, patient is too sick for, proving it that for a thoracoscopy. Well, in such a situation, you may consider, if you have ruled out tuberculosis, you have ruled out, say pulmonary embolism, etc., you may then consider putting a tube and doing a pleurodesis if the patient is too much troubled by a refilling pleural effusion.
Okay, sir. So last question, sir. Should we use NSAIDs or steroids after pleurodesis?
Yeah, I think that's a very, very good
question.
Sir,
sorry to interrupt you, sir, but we are running late of time, sir.
Yeah, this is the last question. This is the last question. This is the last question.
This is the last question. So basically, the answer to that is that don't use steroids, because steroids are known to interfere with pleurodesis and the chemical sclerosis, while NSAIDs can be used even though for pain, if the patient has pain, but and they will not interfere with the pleurodesis.
Okay, sir. Thank you for the wonderful session. On behalf of Academy of Pulmonary and Critical Care Medicine, myself and Dr. B. Jayaprakash, thank you all once again for this opportunity. Thank you.
Yeah, thank you very much, and it's been a
Back
pleasure.
to organizers.
I look forward to some more discussion in the panel discussion. Thank you so much.
Thank you, Rajiv, sir, and the chairperson, sir. I would like to invite our next chairpersons, Dr. Rajesh Varannakar and Dr. D. Behra. Dr. Rajesh Varannakar is a chief pulmonologist and director from Getwell Hospital and Research Institute, Nagpur. And Dr. D. Behra is a director, pulmonology, Fortis Hospital, Mohali. Over to you all, sir, to invite the moderator.
Thank you all on behalf of Indian Chest Society, and we have got Dr. Behra, or also president. I will hand over to him. Dr. Behra, sir, if you can unmute, sir.
Yeah.
Unmute, sir. Yes.
Yes, thank you, Rajesh, and a very good evening to all of you. I think there is a large gathering, a lot of people have joined. And I think I was listening to the wonderful discussion with the, Dr. Goel. So, yes, Rajesh, I think we are thankful that we are associating with the Academy. And it is our pleasure on behalf of the Indian Chest Society. I again welcome you all. So, Rajesh, please you continue. Continue, Rajesh.
Yeah, so I think we will go to the panel discussion, and I would invite Dr. Ullas Batra, who is also senior consultant and chief of thoracic medical oncology, Rajiv Gandhi Cancer Institute, and also Research Center, Delhi. I would invite the other panelists who have just given the talk, Dr. Rajiv Goel, Dr. Ajay Yadav, Dr. Vanita Narona, and also Dr. Abhay Kapoor, Dr. Nikhil Bansal, Dr. Pavan Kumar Biraris, and also Dr. L.M. Darlong, and also Dr. Nipun Lamba. Over to you, Dr. Ullas.
Yeah, thank you, sir. And it's wonderful to see such a huge audience at 8:20 in the evening on a very chilly, at least the Delhi winter actually. So, and my job has been made very simple by the amount of questions that have been answered by Dr. Rajiv Goel and Abhishek. So, I have been asked to conduct a panel discussion on the management of pleural effusion. And when I first saw it, my first reactions, at that time was, that's easy, man. It's pleural effusion. I do it for a living, actually. My subsequent reactions after listening to the previous speakers and, answering what Dr. Rajiv Goel was asked to, was the more I learned, that the more I realize how much I don't know. And the more I talk to Dr. Rajiv Goel, I realize that I don't know much, actually. But that's the privilege of working with Dr. Rajiv Goel and Dr. Abhishek Bansal, Dr. Chaturvedi, and, I actually feel that thoracic tumor boards, we have one every Thursday. I have learned more about the management of pleural effusions and stentings in those sessions than I actually learned during my DM. So thank you for the MDT support that I actually get over there. Now coming on to, because we are running short of time, and let me ask one very basic question to all my panelists, and I'll start with Dr. Vanita. Dr. Vanita at Tata, who manages the pleural effusion in your setup? I'm sure it is not the medical oncologist. Is it the surgical oncologist? You have an interventional pulmonologist, you have an IR, or any other person?
Ullas, so in our setup, again, it's a multidisciplinary management, and it involves the surgical oncologist, the pulmonologist, and the interventional radiologist.
So who is your first go-to man? Who is your first go-to man or a woman? Dr. Sabita is also there.
So I guess there isn't any first go-to person really. We have actually started a clinic with our pulmonologist. So we evaluate, especially all of these difficult to manage pleural effusions or other pulmonary disorders. So we look at the scans together, and then we decide, is this person best suited for a pigtail? Is this person best suited for an ICD or something else? And based on that, we decide. So there isn't only one specific specialty.
I am 100% sure, Dr. Vanita, you should definitely stand for the assembly elections in Maharashtra next year with a kind of absolutely politically correct answer that you give me all the time. I am not going to ask Dr. Darlong and Dr. Abhay Kapoor and Dr. Rajiv Goyal at Rajiv Gandhi because it's an MDT meeting. We're going to get the same answers. Dr. Nikhil Bansal at Fortis.
Yes, sir.
Yeah, hi. So you are the surgeon. So is it your
sir,
IR guy?
Sir, I'm an intervention radiologist.
Okay.
Yes, sir. So it's basically depends on the case, whether the patient having a generalized free fluid or whether it is a loculated effusion, whether the patient having a more than 1 mm size septation. So if the patient having a more than mm size septation or it is a dense one, we send the patient to the oncosurgery team or the pulmonologist for the thoracoscopy. Otherwise, in majority of the cases, either we or our palliative medicine team, they do the
honors.
Yes, sir. Yes, sir.
So, Dr. Nipun?
Yes, sir, Doctor.
Good evening, sir. A very good evening,
hi, Dr.
sir.
Nipun. So who's the captain of the ship there?
Sir, I'm from the same institute, Mahatma Gandhi Institute, as Dr. Nikhil Bansal is there. And we follow the same protocol as he just told us, sir.
Fantastic, fantastic. Let's just move around over there. Most of the time, I think all the big institutes are getting the all the the MDT teams, and that is very, very important. Let me again come to you, Dr. Nipun, once. Out of the last 100 patients of pleural effusions that you have seen, how many, just a ballpark figure? I'll ask you this question, then I'll ask Dr. Rajiv Goyal this question, and then I'll ask Vanita this question. Or maybe I can take it to Dr. Pavan Kumar. How many people in the last 100 pleural effusion patients have got a tapping, have got a pigtail, medical thoracoscopy, an IPC, or a decortication? Just a ballpark figure.
Sir, I think Dr. Nikhil will be a better candidate to answer this
Dr.
question
Nikhil.
because he's our chief interventional radiologist there, and he's dealing with all those details.
Sure, Dr. Nikhil, just a ballpark figure.
So majority of the patients have, like if we compare, if we count in 100, the 30% cases goes for the pigtail, 60% goes for the pleural tapping, sir. 5% for the thoracoscopy, and similarly the 5% for the tunnel catheter. Yes, sir.
Okay. So we are still at to 60 for tapping, 30 for a ICD, probably 5 for a tunnel IPC. How many patients of, let's say the surgeons for decortication for trapped lung and all? Very few?
Yes, sir, very few, sir.
Okay. Let me ask Dr. Pavan from Tata. What is your experience?
I agree with our panelists. Majority of the patients go for USG guided tapping. Few of them who require a pleurodesis depends on ultimately the final decision depends on multiple factors, whether you have loculated effusion, trapped lung, IPC versus tube, all depends on that. So more than 60% definitely UHG tapping, followed by a chest tube, and then further pleurodesis depending on the pathology. Few of them undiagnosed pleural effusion come to me for medical thoracoscopy, and tunnel pleural catheters are very few. I agree with 5% probably.
How many medical thoracoscopies and how many tunnel catheters in the last, let's say, 1 year?
So our cytology department is very strong, and I get diagnosis most of the times in cytology. So medical thoracoscopy, advanced, if they want to run molecular markers and the IHCs and all those, they need more tissue. So about 5 to 10% of patients, most from the breast cancer and lung cancer, come to us. Other than that, tunnel catheters, I agree with 5% and less than that.
Okay, let
It's
me come to
affordability
Dr.
issue
Rajiv Goyal.
ultimately.
Dr. Rajiv Goyal, so you spoke a lot about the tunnel catheters and medical thoracoscopies. So what is the situation at RGCI, where we work?
Yeah, see, I think if you put the whole thing in perspective, virtually all the patients get tapping at least once, right? Now, having done that initial tapping, depending on whether you are dealing with a patient who has undiagnosed pleural effusion, if he has an undiagnosed pleural effusion, if he doesn't have an obvious mass on the CT or a nodule on the CT, he goes for medical thoracoscopy, which would mean about 5 to 10% of the cases. Most of the patients are who would get either on cytology or because of other reasons the thoracoscopy is, for example, not possible.
What about the tunnel catheter versus the pigtail, sir?
Yeah, so having said that, next the thing comes to what you are going to do in terms of treating the patient. So there the situation is that I think what we are basically doing in Rajiv Gandhi is that we have found that the tunnel pleural catheter can be put for a large number of patients. However, the situation in India is such that you have to be very sure that the tunnel catheter will be taken care of at home. So my take on this is, and I think that should be the take for for all of us, is that if the patient is able to look after the catheter at home, which means that there is a caregiver at home who can help in drainage of the catheter and make sure that the catheter is not going to get infected. That is the patient who may be offered a tunnel catheter. We have also looked at the cost of tunnel catheter versus the pigtail drainage. We find that the cost is almost the same because 4 or 5 days of stay in the hospital versus the 30,000 rupees tunnel catheter, the cost remains the same. However, in those patients where there is a trapped lung, then tunnel catheter becomes a good idea. Where there is not a trapped lung, then you may offer either a pigtail catheter with pleurodesis, one go, like Abhishek said, or if he opts for going home early, then he can have a tunnel catheter with autopleurodesis taking place or a talc pleurodesis later on. Very few cases we are referring to Dr. Darlong, who's here also, for decortication, but I would tell you that there are those certain subset of patients who got a good performance status, who are doing well otherwise, who have a loculation which needs decortication, and in those situations it is worthwhile to keep in mind that these patients all do not have a completely dismal prognosis. They should be also a surgical opinion should be sought in those few cases where the patient may benefit from a decortication. I hope that answers the question.
Ullas, can I come in for a minute?
Yeah, definitely, sir.
Yeah, you see, I think Dr. Rajiv very nicely he summarized, but I think one or two things we must remember and must be very careful. One thing is not all pleural effusion because of malignancy will need a intercostal tube drainage. I think that has already been discussed. But again, one more precaution, very specific precaution was to be taken is that whenever you are deciding to put in a intercostal tube drainage or a pigtail drainage, then you see that there is no proximal obstruction. Otherwise, you will be stuck. The lung will not expand and you will end up with the putting the tube, and I think that has already been told. But these one or two precautions one has to take and keep in mind.
Fair enough, sir. Yeah, thank you, sir. Dr. Darlong, I actually don't envy the thoracic surgeons. In stage 1, you have a radiation oncologist giving SBRT. You have a IR person giving RFA. In stage 3, whether you used to do mediastinoscopy, you have now EBUS people coming up over there. In trapped lung, now decortication is there. So, Dr. Darlong, are we reducing? And I just saw Dr. Ramakant Deshpande also was there. So, what is the what is the experience been for decortication for trapped lung actually, and how many procedures, how good, how bad? Is it really something to be even thought about?
Okay, Ulas, I was really waiting for your question. And I would first begin with saying that lung cancer stage 4, you medical oncologists are talking about a lot of target therapies, the good behaviors, the PD-L1, immunotherapy, all these things. So I will take it at a different level. Most of these effusions can be managed with a catheter, epical catheter, most of the times. It is those few cases wherein you got loculation, secondary infection, and lung is trapped. So these are cases wherein basically a thoracic surgeon needs to come in. And decortication is not specifically very much indicated in CA lung because the whole lung is plastered with a disease. So you cannot go and basically re-expand the lung. I will go more aggressive one step ahead. And I will say that in such cases, when you got empyema, a pleural window definitely makes sense because it is one-time procedure. You are basically eliminating the source of infection, and the patient goes on to have his chemotherapy, immunotherapy, target therapy. And we don't have too much of experience in doing pleural window because acceptance is low. It is basically those very fit patients which you have referred that we have done on them, maybe about 2 or 3 of them. And they are still basically on chemotherapy and they are tolerating the chemotherapies and immunotherapies. They are still surviving with the disease. And so I think definitely we need to explore more of this surgical procedure, not decortication mainly. Decortication is useful mainly for other malignancies wherein you have got a pleural effusion because of that malignant effusion and it's trapping the lung.
Okay. Let me now
So
go on.
Pleural window is something we need to consider for fit patients wherein you can basically control the local site of infection and then you can continue the other therapies.
Okay. Dr. Vanita, can I get you in on this? Let's say you spoke about you have an MDT meeting and where you discuss over there. Now let me ask you a question. Let's say a patient comes to you with cough with breathlessness grade 2, on X-ray has a moderate pleural effusion. How do you decide, for the benefit of all the 150 people who have joined over here, whether you want to go ahead with a single time aspiration versus how do you want to get a drain put? What are the factors? Does it depend upon the strategy depending on the type of cancer? Does it depend upon the wild type versus biomarker driven lung cancer? How do you take a call? Clinical.
So this is a patient who is not diagnosed a case of malignancy. So I guess initially, the first question is it a diagnostic or is it a therapeutic tab? So if you don't have a diagnosis, then clearly you will just do a needle aspiration and send all the diagnostic workup. If you already have a diagnosis of cancer, then all of these factors come into play. So how symptomatic is the patient? I mean, the reason for managing the pleural effusion is the symptomatology and the quality of life of the patient. So how symptomatic is the patient? What do you expect the response to chemotherapy or targeted therapy to be? And so all of those play into your management decision process. So by and large, it's first time it is needle aspiration, just a small volume or a large volume, depending on the symptomatology. And then based on all of these factors, we make the next decision.
A very important question, Dr. Rajiv, I would like to ask you is, sir, when you are sending a single time aspiration, let me ask Dr. Abhay Kapoor. Dr. Abhay Kapoor is an interventional radiologist at Rajiv Gandhi. So when you are sending a single time aspiration with the ultrasound guided, what is the volume of fluid? This is for the benefit, we all say cell block. Now, do you send the entire 500 ml? Do you send 50 ml? Do you send 1 liter? How much do you send? Dr. Abhay.
Normally, if a patient is sent for a single time aspiration, the first question which comes to mind is it only diagnostic or is it therapeutic? So if it is diagnostic, I will aspirate only 100 ml using the 22 gauge needle, the least invasive for the patient. But if it is going to be therapeutic, so we put in the cannula and whatever amount, if I've taken out a 1 liter, but I will still send only 100 ml to the lab, which as per a lot of studies is sufficient enough to diagnose any malignant cytology if it is the malignant cells are already existing in the fluid.
So Dr. Rajiv, do you agree with that? The more the better, or 100 ml is good enough, sir?
No, 100 ml is good enough, and that is usually, it will tell you clearly whether you have got enough, whether there are malignant cells or not, that is enough to tell.
Okay, so now let me come, because we're already late, let me come to the meat of the matter. Now, let us say you have a patient who has been diagnosed with non-small cell lung cancer. The patient requires he or she has undergone a therapeutic aspiration twice or thrice, requires repeated tappings. How do you decide? Now, again, this is a very basic question for the medical oncologist. How do you decide between pigtail versus IPC? Let me ask Dr. Pawan Kumar first, and then I'll take Dr. Rajiv Garan, because you've heard his opinion. Dr. Pawan Kumar.
Yes, sir. So, Dr. Batra, the effusion management depends on multiple factors. Whether you have free-flowing effusion, you have a loculated effusion, or you have a trap lung. Means you have endobronchial obstruction and lung is not going to expand, or there's interstitial lung disease simultaneously.
So you do not have
a,
in this particular, let us start the simple. You do not have an endobronchial obstruction. The trachea shifted to the other side. So let's see how you approach that. Between pigtail versus IPC. Let's say it's a PG student who is listening to this, sir.
So you drain the fluid, you relieve the symptom with a complete drainage of the fluid. Or intermittent drainage of the fluid to avoid the re-expansion pulmonary edema. The catheter can be used as a pigtail or intercostal drain, whatever you have available in the institute and what your patient is going to afford, what expertise you have. If you have a PG student who is trained in intercostal tube drainage, you put an intercostal tube drainage, which can be 16, 20 French or 24 French. A pigtail available, patient is affordable, you have expertise to put, you have ultrasound guidance, put a pigtail. Ultimate aim is to drain the fluid. So first will be a pigtail catheter. IPC doesn't come first during my experience as well as during the post-graduation training as well, because most of patients are not affordable for that. But if you ask pigtail versus IPC in a massive pleural effusion, anything is good for drainage of the fluid. First choice is always a catheter, pigtail or ICD.
Okay, Dr. Rajiv. So let's put Dr. Goyal. Let's keep the money out of it. And you also came to you also took an analysis where you said money was not really an issue. How do you decide, sir, when I refer a patient to you about, how do you decide between, we had a discussion around a month back. How do you, in your practice, decide between ICD versus an IPC catheter, sir?
Yeah, so I think we already said and talked about that in the previous sort of few minutes, but basically I'll just reiterate the point that if you have a patient who doesn't have a trapped lung, and in which you need to drain the fluid, what we normally are doing now is to give them the option of two kinds of drainage procedures. One, which is going to mean that he has to stay in the hospital for 3 to 5 days, during which the fluid will be drained out through a pigtail catheter. And once that is done and the lung re-expands, we will do a pleurodesis and come out and hopefully get the catheter out. So that is one way of doing it. The other way is that an indwelling pleural catheter can be put where the fluid will be drained out as much as is possible in one go. After that, the patient can be discharged maybe the same day or the next day. And after that, the patient will be taught how to do the drainage himself at home every second day or every third day. And then he comes back to us after a week or 10 days, after which if the fluid has, drained out completely and there's not much of fluid draining out, then you can go for a talc pleurodesis. Or if the patient is, still draining fluid, then he continues to do a self drainage at home and then comes back to you again after a week or 2 weeks. And then we may follow suit, like I said.
So can I just, sir, Dr. Rajiv, okay, go ahead, sir.
Now just let me finish. So basically these two options are given. We also look at the educative, the level of education of the patient and his caregivers. If the patient's caregivers are such that they understand how the pleural fluid is to be drained, we get one of the caregivers in the OT itself, show him how the procedure is, the drainage procedure is done. Same day, next day before going, again, we make sure that he understands how it is done. The need for sterility while, the aspiration drainage is done at home. And if he has any issues, we give him our number and we have his number so that we can be on constant, communication with him so that in case at any time he has a problem. See, the difference between the West and here is in the West, they have these, nurses who go to the patient's home who will, help out with the drainage and, help them to understand how it's done. While here we have no such support. So we have to be very, very sure that the patient should be able to manage the catheter at home with his caregiver. And then if that is so, then we say, okay, you can go with the IPC if you would want to, be discharged quickly. So that is how we do it.
Sure, sir. Can I take Dr. Vanita's comment on this? Dr. Vanita, what proportion of your patients are undergoing ICD versus IPC?
So
Just a ballpark figure.
IPC almost hardly any. So by and large, it would be ICD or a pigtail. So the tunneled, you're talking about the tunneled indwelling.
The tunneled one, yes.
Yeah,
so what is it that is
any.
prohibiting us from putting a tunnel catheter in your setup? Cost. Okay. In fact, there are two comments to which that I will like to make. I had that discussion with Dr. Rajiv Goyal, and the comment which I got from it is not the financial status of the patient which is important in deciding between IPC and tunnel. It is the mental status of the attendants which is more important in deciding, they should be able to take care of the infection. That was the first thing he said. And the second thing, Dr. Rajiv, sir, I have a comment on that is, it is easy to give numbers, but who will pick up their phone? That is the only thing. They can keep on calling.
Other than the cost of the catheter, those bottles also are expensive. Those vacuum bottles, which have to be replaced, on an ongoing basis. So that's very, very difficult for our patients.
Dr. Vanita, let me just say that problem has been sorted out. That those bottles are no more required. Both the Pleurex people as well as the Rocket Fusion people are giving detachable sort of valves with the catheters, so you don't need those disposable bottles anymore. And so that cost has been taken out of the equation. And so now you can just drain it with a three-way sort of syringe, and that is not a problem anymore. So if that is a problem, don't figure that into your calculations, because that is no more an issue.
I didn't know this, sir. Thank you. This is very good information.
I think Ullas, the issue is that with the IPC, it's a labor-intensive thing, both for the patient and for you. So you have to be ready to be able to give that kind of service if you are going to put the IPC. Putting the IPC is not the problem. Anybody who can learn put the IPC, but then he should be able to give that kind of service and support to the patient that, yes, if you have a problem, I am there to take care of it. And that is true for all IP procedures, whether it is stenting, whether it is something you are married to the patient and you have to sort of nibhao that marriage.
Sir, ये marriage वाली बात यहाँ मत करो. I'll start with my jokes and it will be difficult over there, sir. So we will talk about that later, sir. So Meenu is also listening, sir. So I will not talk about marriage over here, sir. There's a small question over here, sir. How much fluid should be drained? Dr. Abhay, maximum fluid in cases of a unilateral effusion, in case of bilateral effusion.
We can drain 1 liter easily in case it is unilateral, and in case most of the malignant effusion, if it is bilateral, you can drain 1 liter from each side. The only fear is of the pulmonary edema, and each side works separately. So you do not need to be scared about it. You can drain 1 liter on each side.
Okay. Dr. Gurunak, hi. He is asking any views on pigtail with a valved Eurobag for a OPD-based management. Dr. Rajiv Goyal, if you can take this one.
You can use a Eurobag. The problem with the Eurobag is that it's very difficult to make out, things like air leak and things like, if there is if the column is moving or not. So which is why we don't use Eurobags. You can use a Eurobag because it acts like a Heimlich valve, kind of. So air will not get in. But that is why we don't use Eurobags, because you can't see column movement properly, and you can't, appreciate any air leak properly.
Okay. Sir, I've got some more doubts. So let me start asking some more doubts. Okay, here we go. Can I ask Dr. Nikhil Bansal this, and then we'll go to Dr. Pavan Kumar.
Yes,
rapid pleurodesis or delayed pleurodesis? Any rule of negative suction? I still remember sometimes back we had a huge that 3-wala machine which was connected to the patient for expanding the lung. Are we still doing it? And what about the rapid or the delayed pleurodesis?
Sir,
Dr. Nikhil first. Yeah.
I don't have much experience about this particular thing, sir.
Okay, Dr. Pavan.
So rapid pleurodesis was delayed in the sense you do the thoracoscopy and immediately do the pleurodesis.
Yes.
This is the question. So yes, if we send the frozen, we get the diagnosis, we get multiple tissue samples. So the tissue is never inadequate for us. We get multiple samples, and you can consider the pleurodesis in the same setting. Delayed pleurodesis in the sense the traditional approach that you don't have the fluid drainage for last 3 days, 50 ml or 150 ml for less than 3 days, and you can consider for a pleurodesis. It depends on the kind of situation. It is individualized ultimately. Second question is any role of negative suction? Previously, we used to use that. Even after pleurodesis, we sometimes used to put a negative suction after 1 hour of pleurodesis and declamping the tube. But no major added benefit we have seen when the lung is going to expand completely. And even in thoracoscopy, you can gauge that when you put a negative suction with your with the thoracoscope, you can see the lung coming up. So most of times, negative suction is not required.
Okay, so Dr. Rajiv, I think your just 2 brief line comments about rapid or delayed pleurodesis. The first question.
So rapid pleurodesis basically means that you don't wait for the fluid to diminish before taking the tube out. And I think there was a reference to that in one of Abhishek's slides, where he showed that there is a paper showing that, you know, it works as well. You don't get too much out of waiting too long. So you may take the tube out earlier. You don't really have to wait for the fluid to, you know, go down a lot. People who have got very high turnovers of fluid, you know, people who are bringing out 500, 700, 800 ml of fluid. In those patients also, if you do a pleurodesis, negative suction helps, because immediately after the pleurodesis, after you put the sclerosant inside, if you put the negative suction immediately after that, then you are bringing the pleural surfaces together, and thereby you may, you know, improve your chances of you know, getting a better pleurodesis, because otherwise the turnover of the fluid is so much that it will, you know, keep these surfaces apart and not allow the pleurodesis to occur.
So my question over here, Dr. Rajiv, to you at that time is, and that is my problem with the rapid pleurodesis, you know, that you don't know what is the turnover of the fluid going to be on day 0 when you do it, when you do a insertion. If you do a pleurodesis at that time, aren't you more likely to fail the pleurodesis?
So that's why we don't do it on day 0. No?
Yeah, we don't do.
The tube, you put in the tube and then you wait at least for 24 hours to see whether the lung is completely expanded or not.
Okay. So Dr. Vanita, I think we have answered the TAC. I think everybody's favorite is TAC, and we don't use Johnson's baby powder anymore. Steroids and pleurodesis, I think we will take this both together.
Sorry, Ullas, I'll just jump in there. So we are actually currently not using TAC. I think the TAC, we were having quite a bit of problems with infections. And Steritalc is available, but Steritalc is a bit expensive for our patients. So currently we are using Bleo in our hospital.
Okay, fantastic. So, I mean, are you having a trial or
no,
are you going
no,
to compare?
No.
Okay.
No. Just routine care.
Bleo is, the dose of Bleo is 30?
Oh, I don't know. Yeah, that's the surgeon's put. I don't know.
Fair enough. So, ma'am, let's say the chemo and pleurodesis. So, let's say the lung has expanded, and you know, my major problem, let Dr. Rajiv and me put it out in the open, is, you know, they don't want us to give steroids. And how can you give chemo without steroids? So how do you, learning from you, Dr. Vanita, or how do you manage that?
So I think the question of the steroids and pleurodesis is just right at the time of pleurodesis. I don't think it's a blanket contraindication as far as I know. I actually have not given it a whole lot of thought since this until this meeting, this was really a good meeting, and I learned a lot. But you know, I will take inputs from Dr. Rajiv and all of you. I don't know, we just give it routinely.
I know, because the moment, so I'll tell you what happened was, we had some 3-4 pleurodesis failure. We blamed them, they blamed us. So, you know, then we said, okay, fine. Then after that, we decided we blamed steroids for that. So Dr. Rajiv, I'll tell you what I do. First your comments, and then I'll tell you what I do.
So basically, I think what you do is you time your procedure, you know, properly, which means that I will either do the pleurodesis and then wait for a couple of days before you give the chemo, or you will give the chemotherapy and wait for a couple of days and then do the pleurodesis. So basically, it's a question of timing. You need to give about 48 hours before the Dexona is given, and you know, or after the Dexona is being given, to allow the pleurodesis to be effective. So that is what we are doing, and I think that is the, you know, appropriate way of going about it. So you need to be in sync with your medical oncologist in terms of when you want to time your pleurodesis.
Fair enough.
Ullas,
yes,
if I can comment for a minute, you know, I don't know what is the view of Dr. Rajiv about you know, chemical pleurodesis with the other agents. Obviously, talc pleurodesis is the best. What about providone iodine? Because that is what PGI routinely does it.
Yeah, so I think people also, so I think they've gone to talc now, because basically the thing is that povidone iodine, the results are not as good as talc.
Yeah.
So basically, you can use povidone, and I think we talked about this question before you came in, that there was this question about povidone iodine, and the answer is that the results are not as good, but it's still a good alternative in those situations where the patient can't afford it. And the other advantage of povidone iodine is that other than iodine sensitivity, there are no other major reactions with it. You can reuse it if necessary in a case where who has failed once. So we used a lot of povidone iodine before talc came in, but now we are using talc.
Okay, sir, I think, thank you. So we are slightly late, and this is to Dr. Nikhil Bansal and then to Dr. Abhay Kapoor. Non-expanded lungs after catheter placement. Let's say you have put an ICD or something and the lung is not expanding. What do you do? The medical oncologist is obviously going to blame you. The patients are going to look at you with those eyes, that usi ke baad sab kuch kharab hua hai. So how do you manage that? The lung is not expanding.
I think we usually refer those patients to the pulmonologist.
That's okay. Dr. Pavan Kumar.
So, sir, we need to. Yes.
Actually, there's a limit.
Dr. Abhay first and then Dr. Pavan. Dr. Abhay first.
So you can drain only up to 1 liter in a day. And if that's the amount that you're getting and the production is higher or the lung is not expanding for whatever other reasons, the interventional radiologist actually will not be able to add on much to this. All that our catheters can do is drain the fluid out. But if still the lung is not expanding, then I'm sure Dr. Rajiv Goyal is going to come into play.
Okay, Dr. Pavan and Dr. Rajiv Goyal is having a smile of his life. All roads lead to Rome. All roads lead to Dr. Rajiv Goyal. Dr. Pavan first.
So, when we start deciding on management of pleural effusion, you look at the X-ray. Your mediastinum is central. You have a moderate or massive effusion. You know that there is something which is holding the lung central. So there is either endobronchial lesion or there is something in the lung which is not allowing it to expand or displace the mediastinum to one side, the opposite side. So that gives you a clue that there is something else is happening. You have a CT scan or contrast CT done and it will tell you about something about endoluminal component for sure. Then you go for a diagnostic or a therapeutic pleural aspiration and you see during that time your lung is expanded or not. So if lung partially expands or even if you have leftover of about 500, 600 ml moderate pleural effusion, that is the time you decide about this is going to expand further. I need to do another imaging to look for ultrasound also helps during that time. So multiple factors play in place. If suppose there is a good response to the chemotherapy is going to be expected for the primary tumor, then we wait for the chemo to kick in and then see whether the lung expands or not. If there is an endobronchial thing which is holding the lung, trapping the lung, then you have an option of releasing the endobronchial obstruction and letting the lung expand and then further consider. Ultimately, if the lung doesn't expand, the fluid fills, patient is symptomatic, it comes to the ambulatory pleural fluid drainage versus IPC versus the chest tube, whatever is available.
Yeah, true that. So, very importantly, look at the medius and the Yes,
Ulas.
Dr. Dalong.
Yeah, I think I need to come in
were
here.
Also there. Sorry,
these are the cases wherein you basically need a thoracic surgeon. These are the particular cases wherein there is a role for decortication, though very limited, if it is basically trapping the disease is trapping the lung, not because of the fluid, the collagen, the fibrinous layer. In that case, decortication is not possible, but it is empyema. So these are cases where in the pleural window, you do a diagnostic thoracoscopy, you see that the lung is trapped, you can do a decortication. In some cases, not all. If the disease is on the pleura, then in that case, you can't do a decortication. So if there's a collection, in that case, you can make a pleural window. So this is basically like the treatment done for empyemas previously, and mainly in tuberculosis. This can be applied in such select cases, which I said we have done in few cases. So these are, I think, the cases wherein you need to really see, the role of thoracic surgeon when everything has failed. This is exactly where we come in and intervene.
You are my savior. You all are my saviors. I will.
Can I ask one thing, Ulas?
Yeah, yes, Dr. Vanita. You're asking or you are pulling my leg?
No. I'm genuinely asking. Have you all ever done decortication for these trapped lungs? Because we see it, and the patients are really quite miserable. But normally we just put we remove the tube and put a colostomy bag or something and continue on. So, do you all ever do any surgical procedures?
Dr. Dalong?
Yes, we do, Dr. Vanita. We do. These are cases who come in, not many of them. It's a few select cases, basically good performance status. well motivated. And we are doing surgery, it's not invasive, like it's a thoracoscopy. And it is done under single lumen. We don't use the double lumen tube in such cases. And we just put in a scope, see if a decorticing is possible. And we can be done using a single port, uniportal we call it nowadays. And if it's not possible to re-expand the lung because of the disease process overlying the pleura, in that when we excise the rib, about 2 ribs, and make a window. And so we don't let the collections drain inside. The infection focus is taken care, and the chemotherapy or any systemic treatment continues with that.
Dr. Darlong, if I give you more time, you will in fact do the pleural window itself right now. So just wait. Let me ask Dr. Rajiv, and this is going to be my last question probably because we're already 20 minutes late. Sir, the third question for you. The second and third. How do you manage pleurodesis failure, and how do you deal with multiple loculations?
I think Dr. Darlong sort of wants to go for his dinner quickly, so he thought of preempting got on to decortication. But just before the decortication part comes in the role of additionolysis. So you can use streptokinase. We've been using it quite frequently, although there have been doubts raised about allergic reactions and all, but we have not really encountered it. But streptokinase can be used to lyse the fibrinous adhesions many a times, and it works very well in malignant pleural effusion. There are several papers which have been which show the evidence, and we have found that in those cases where the tube stops draining for some reason, lung doesn't seem to expand.
Just I'll talk to you.
And then you may consider, putting streptokinase 250,000 units every 12 hours for 2 to 3 days, and that many a times will facilitate the drainage, and many a times the lung will expand. So that is one more thing that can be done before you consider a surgical option. And so that is the answer to your question.
Okay, I think that was it, and we are 20 minutes late. I could have actually gone ahead with this for half an hour more because I've got so many doubts regarding pleural effusion. But just to conclude, I think I started off with saying the more I learn, more I talk to people, the more I have doubts. But I think I will end by concluding the more I learn is the more I learn that I have more to learn. So I think it was a fantastic session by the Indian Academy of Lung Sciences involving the IP people, the IR people, the surgeons, because it's very important that we understand each other. And this was a true MDT meeting. And I would like again to say that it's the teamwork is a success basically. And thank you everyone for helping me actually grow and learn. I knew we will learn a lot, so I already put this slide over there. Thank you, and hand it back to the organizers. Thank you.
Thank you so much. Thank you very much.
Thank you, Dr. Ullas, for this wonderful panel discussion. I would like to thank you all, our program directors, program convener, and all our faculty. I'd like to thank our partnering society. There are quite a few: Indian Society of Vascular and Interventional Radiology, Indian Association of Surgical Oncology, Academy of Pulmonary and Critical Care Medicine, Indian Society of Oncology, Indian Society for Study of Lung Cancer, Indian Society of Medical and Pediatric Oncology, Indian Chest Society, and Indian Society of Bronchology for helping us plan and execute all Academy of Lung Cancer initiatives.
Can I please ask Dr. Kumar Prabhash to say the final words, because it is actually his brainchild to get all of us. I think he's quietly sitting in the background, but it is Kumar who deserves all the applause for this actually. So Dr. Kumar, your final words on this.
Thank you, Ullas. It was really nice, and I learned a lot. And thank you, especially you and Dr. Hemant sir, for this nice session. And sure, we will have more as we had decided, and a similar session with having all people together and learning from each other. Thank you, everyone, again. Thank you so much.
Thank you.
Thank you so much.
Thank you very much.
Thank you all.
Thank you for the invitation. Bye.
Thank you, Ullas sir. Thank you.